Hi everyone, my name is Zaineb Ukra and I'm a radiology registrar at the Auckland Training Scheme in New Zealand. Together with my supervisor Dr. Jenny Davidson, we conducted an audit looking at the rate of cases in Auckland, New Zealand who have undergone both technetium DPD scintigraphy as well as endomyocardial biopsy in order to diagnose transthyretin cardiac amyloidosis. The two most common causes of cardiac amyloidosis is light chain cardiac amyloidosis and transthyretin cardiac amyloidosis, or ATTR. ATTR cardiac amyloidosis can be hereditary or wild type, and it is a challenging and underdiagnosed condition. Cardiac amyloidosis occurs secondary to the deposition of misfolded protein into cardiac tissue. And the result of this is disruption of cardiac architecture and therefore impaired cardiac function. Cardiac amyloidosis is characterized clinically by features of restrictive cardiomyopathy, and it's usually diagnosed in men over the age of 50, and prognosis is often poor with a mean life expectancy of 5 to 6 years after symptom onset. Electrocardiography and echocardiography can both be used in the diagnosis of cardiac amyloidosis. However, they're not very specific for diagnosing early or mild types of the condition, and they also don't provide information on the etiologic type of the condition, i.e. ATTR versus light chain. Cardiac biomarkers, including BNP, troponin, creatinine, and eGFR, can also be used in aiding the diagnosis. So, technetium DPD scintigraphy has been used worldwide since the early 2010s. Auckland District Health Board, a public entity, and New Zealand Medical Imaging, a private institution, are of the few centres in New Zealand which actually perform DPD scintigraphy. It has proven to be highly sensitive and specific in the diagnosis of ATTR cardiac amyloidosis, including in early and mild forms. There are reports of up to 100% sensitivity and 88% specificity for the diagnosis of ATTR, cardiac amyloidosis. This is useful for early diagnosis of the condition and therefore starting therapies to slow the progression of the disease. DPD scintigraphy imaging is given a final grading score, the Perugini grading. Perugini published one of the original papers looking at the use of DPD scintigraphy in the breakup of amyloidosis back in 2005. So just some examples here. With grade 0, there's no cardiac uptake. Grade 1, cardiac uptake is less than bone uptake. With grade 2, there is similar cardiac and bone uptake. And with grade 3, cardiac uptake is greater than bone with reduced or absent bone uptake. So basically grade 0 is a negative result, grade 1 to 3 is a positive result, and grade 2 to 3 is a high grade positive. An older technique used in aiding diagnosis of cardiac amyloidosis is endomyocardial biopsy. This is a more invasive technique than DPD scintigraphy, and it's used to obtain cardiac tissue in order to achieve a diagnosis and allow treatment guidance or prognostic value. Because histological findings are frequently non-specific, specific tissue diagnosis is usually only successful in a minority of cases. Endomyocardial biopsy is typically performed through the right internal jugular vein, with biopsy of the interventricular septum most common, as the right ventricular wall is thin in comparison. Endomyocardial biopsy is usually performed with the guidance of echo or fluoroscopy. And as with any invasive procedure, all patients who undergo an endomyocardial biopsy are at risk of complications. In most case series, the rate of complication is reported as less than 6% and includes things such as transient right bundle branch block, transient arrhythmias, access site hematoma, tricuspid regurgitation, and pulmonary embolism. A similar complication rate of 5.5%, or 4 of 73 cases, has been reported in the largest study evaluating the safety of endomyocardial biopsy in cardiac amyloidosis patients. Life-threatening complications such as right ventricular perforation occur much less frequently, less than 1%. Cardiac amyloidosis is confirmed when an endomyocardial biopsy demonstrates amyloid deposits after Congo red staining, irrespective of the degree of left ventricular wall thickness. This guideline, proposed by the European Society of Cardiology, has a non-invasive pathway which is used for the diagnosis of ATTR cardiac amyloidosis. It includes needing a grade 2 or 3 cardiac uptake at scintigraphy scanning, and also requiring negative serum and urine-free light chains, as well as cardiac MRI or echo features that are consistent with cardiac amyloidosis. So basically, this non-invasive pathway negates the need for cardiac biopsy or endomyocardial biopsy. So the aim of our audit was to quantify the rates of cases in Auckland, New Zealand who have undergone both DPD scintigraphy and endomyocardial biopsy in order to diagnose ATTR cardiac amyloidosis, and to therefore see how DPD scintigraphy has shaped the diagnosis of the disease in our population. This was a retrospective outcome analysis, and the audit was conducted between 26th of February 2020 and 9th of December 2021. Data was collected by using the IMPACTS database of all DPD scintigraphy performed at Auckland DHB and New Zealand Medical Imaging, and cross-referencing these cases with radiology and biopsy reports, as well as discharge summaries from the medical records on the regional clinical portal. Data was then collated onto an Excel spreadsheet and analysed. Information that was obtained from the IMPACTS database included the date of DPD scintigraphy, as well as the Perugini grade, and information taken from the regional clinical portal included patient age, gender, and ethnicity, whether an endomyocardial biopsy had been performed, and if so, what the result of the biopsy was, whether there were any reported complications post-DPD scintigraphy or endomyocardial biopsy, also whether any other tissue diagnosis had been performed and the result of that, and also cardiology clinic letters were reviewed. Altogether, there were 37 cases of DPD scintigraphy performed in Auckland, New Zealand. 30 of these were through the public system at Auckland District Health Board and 7 through private at New Zealand Medical Imaging. All DPD scans that were performed were used in this audit. There was no exclusion criteria. So, of the 30 cases or scans that were performed at Auckland DHB, 53.3% returned a negative scan result, 46.7% returned a positive result, and 36.7% returned a high-grade result, or a Perugini 2 to 3. Of the 7 cases performed at New Zealand Medical Imaging, 28.6% returned a negative result, 71.4% returned a positive result, and 57.1% returned a high-grade positive result. So of the total 37 cases, 48.6% returned a negative result, 51.4% returned a positive result, and 40.5% returned a high-grade positive result, or 15 of the 37 cases. Of the 7 cases who underwent DPD scintigraphy at New Zealand Medical Imaging, 2 of these cases also underwent endomyocardial biopsy. Both biopsies were performed 5 months post-imaging. One biopsy was negative for amyloid, and this was consistent with the imaging findings of a Perugini grade 0. The other biopsy was positive for amyloid and consistent with the Perugini grade of 3. Similarly, of the 30 cases who underwent DPD scintigraphy at Auckland DHB, 2 also underwent endomyocardial biopsy. One was performed following imaging and yielded a negative result, which was concordant with the grade 0 Perugini grading, and this biopsy, which yielded a positive result, was taken from a sample 3 years prior to imaging, which had undergone retrospective staining. It also was concordant with the grade 3 Perugini grading. So of the 37 total cases who underwent DPD scintigraphy, a total of 4 also underwent endomyocardial biopsy, or 10.8%, and all 4 of these biopsies were concordant with imaging findings. As with any retrospective analysis, there were a number of limitations encountered in this audit. The first of these is regarding collection of information. Because DPD scintigraphy is a relatively new type of imaging, there was a bit of a learning curve in how to report them. Positive scans were always reported with a Perugini grade. However, imaging which was not consistent with amyloidosis was sometimes reported as unlikely, and no Perugini grade given. Such reports were therefore double read by a consultant radiologist and nuclear medicine specialist, and subsequently given a Perugini grade. Collecting information on numbers of endomyocardial biopsies was less consistent, as there is the limitation of possible endomyocardial biopsy being performed in private healthcare. To account for this, cardiology clinic letters were read to make sure if there was mention of biopsy rather than just checking the laboratory results. Lastly, the sample size of this audit is 37, which makes the data less reliable. In conclusion, 4 of the 37 cases, or 10.8%, had both endomyocardial biopsy and DPD scintigraphy in their workup of ATTR cardiac amyloidosis, and 100% of the endomyocardial biopsies were concordant with imaging findings. This suggests that in the Auckland region, imaging has become the preferred modality in the diagnosis of ATTR cardiac amyloidosis over endomyocardial biopsy. This is interesting as it is in line with international guidelines. However, it's still unclear if the international guidelines are consistently used in New Zealand. We are in the process of expanding this research with cardiologist input, looking at cardiac biomarkers, echocardiography, cardiac MRI, and immunoglobulin testing to suggest a New Zealand-based diagnostic pathway for ATTR cardiac amyloidosis. Thank you for listening.